Today, I'll be discussing about the basic clinical neurology and clinical examination. For that, I have chosen 4 topics, that's anatomy, functional anatomy, blood supply of the brain, and clinical examination. Looking at the anatomy, you are all aware that we have got 2 hemispheres. It's a frontal lobe in the front, parietal, temporal lobe laterally, and occipital lobe posteriorly, and below that is a cerebellum, and front to that is a brainstem. And you see the sagittal section, you have corpus callosum connecting both the cerebral hemispheres, you have thalamus, anterior cingulate gyrus, posterior cingulate gyrus, above the corpus callosum, and then hippocampus, amygdala, hypothalamus, and the pituitary gland. Coming to the coronal sections of the brain, and if you cut through frontal, parietal, occipital, you see in the frontal sections, you see lateral ventricle, caudate nucleus, putamen, globus pallidus, septum pellucidum, corpus callosum again, and you see the pyramidal tract at this section coming from the motor cortex, and also the lenticular striate branch of the middle cerebral artery, which is the culprit artery in most or 80% of the stroke. And this section displays the insula and longitudinal fissure, and the parietal section which shows the red nucleus, substantia nigra, hippocampus, fornix, and the ascending sensory tract which travels through the thalamus to reach the sensory cortex. And this section of the parietal lobe shows the sulcus, the final occipital cortex which shows optic radiation and the posterior cerebral artery. Now, functional anatomy. Brodmann has localized various areas and numbered it. So, 1, 2, 3 is a sensory cortex which receives the signals from the receptors of touch, pain, temperature through the spinal cord, thalamus, and then reaches the sensory cortex. So, as it enters the spinal cord, travels to the opposite side and ascends as lateral spinothalamic tract. And another sensory system, that is the posterior column sensation, proprioceptive signals and vibratory signals that are all carried from various parts of the body and reaches the nucleus gracilis and cuneatus, and then ascends through ML and reaches the sensory cortex. Area number 4 is the primary motor cortex, from which the pyramidal tract comes, and at the level of medulla crosses and ends up in anterior horn cells through corona radiata, internal capsule, corticobulbar fibers and corticospinal tract, and causes movement and muscle contraction. And this area number 6 is an associate cortex. Area number 44 is the Broca's area, or expressive motor speech, that is speech production by orchestrating complex muscle movements necessary for articulating spoken words. And area number 41 and 42 again is something to do with the auditory cortex, that's kind of receiving the spoken words or music, and this area is also called Wernicke's area. It's involved in speech listening to make sense of the spoken words or sounds. Area number 10 and 11 is the prefrontal cortex, highly evolved part of the brain, involved in cognitive function, self-reflection, behavior, and working memory. And then 17, 18, and 19 are visual cortex, receive signals through the optic nerve, optic chiasm, lenticular geniculate body. All optical signals are processed here. And extrapyramidal system, you know, the putamen, globus pallidus, red nucleus, substantia nigra, all passes its tract down through 4 tracts. There's tectospinal tract, rubrospinal tract, vestibulospinal tract, reticulospinal tract. Limbic system is a primitive brain which involved in innate reflex, emotion, behavior, motivation, long-term memory, olfaction, and interestingly, it's a survival instinct, the feeding, reproduction, and frontal lobe function, language production. Left and right has special things, and the left has logical and analytical thinking, fine motor control. Yes, the right frontal lobe has got spatial abilities, to including spatial reasoning, emotional processing, to control the emotions, and creative thinking. It's a creativity and divergent thinking, lateral thinking, etc. And any defect or damage to the frontal lobe will cause corresponding defects, and of which the hemimonoplegia is a common presentation, and the Broca's aphasia and expressive patient cannot articulate the words what he wants to say. Patient may have apathy and mutism. Patient may not communicate with others, they just stay still, and they have poor attention to what's going around. They have emotional indifference to the people and to the situation, and also poorly motivated. Yes, and coming to the parietal lobe functions, and left lobe has got a language processing center, which process all the speech language, and mathematical abilities, calculations are done here, and fine motor skills are governed here. And the non-dominant parietal lobe shows the spatial awareness, how things are around in space and judge distances. Right parietal lobe has also got visual field processing and also fine motor skills of coordination and precise hand movements, etc. Any damage to the parietal lobe may cause a corresponding defect, as mentioned here, of which the important ones are the Jessamine syndrome, the dominant lobe dysgraphia. If you draw anything on the skin, they cannot understand, they cannot calculate. Dyscalculia, right to left disoriented. They can't see what is left and right, and they in the absence of fingers, they cannot remember that. It's a finger agnosia. And of the non-dominant lobe, you have acalculia. Calculation is difficult, and putting on the dress in a very coordinated way, the dressing apraxia. Patient three-dimensional tactile sensation lost. If you put a coin inside, they may not be able to appreciate. Hemineglect, half of the body they may hit against, they may not be aware of it. Topagnosia, if you touch on somewhere, they cannot localize. Agraphesthesia, again, if you write a word, they cannot understand the skin of when the eyes closed. And 2-point discrimination, if you put 2 touch points, they may not be able to differentiate the distance between it, or if there is 1 or 2. Coming to the occipital lobe, again, a dominant lobe processes the visual field, and it also processes the reading and language visual process. The written words are processed here. Right occipital lobe, non-dominant, again process the left visual field processing, and it has a spatial awareness and object recognition. And I would like to add a thing that's called, if you open the eye and you see what are things are around in the environment, and you want to see what is what and where is it. So there are 2 pathways called what pathway and where pathway. And if you see area number 17, 14, the occipital cortex, it originates and goes around, and that whatever you see, what is the object, and then or what is the animal, and then where you track it and where it's going. So these are all done in the occipital cortex. And the common defect, if there is a problem, hemiquadrantonopia, field of vision defect, color agnosia, color blindness, word blindness. They can read and they cannot comprehend what is a word which they knew before. Movement agnosia, they have illusion of movement and visual illusion. They see things, hallucination, etc. Temporal lobe, and again the dominant temporal lobe process visual language processing. We have seen that earlier. And verbal memory, the sounds, the sentences, language, auditory processing, and the sound signals are processed here. And non-verbal memory in the right, non-dominant. And emotional processing is done in the right. Temporal lobe, and temporal lobe process the auditory signals, which is non-verbal, like music, non-language sounds. Any problem, again, as I said, the same problem with the memory, language functions are defective. So prosopagnosia, the familiar faces you lost. You can't figure out who is that. Wernicke's aphasia, yes, it's a receptive aphasia. You can't comprehend what somebody is saying. Amnesia, you forget things, what has happened. And paranoia, you are paranoid about things, so you suspect people. Preoccupied, so you're preoccupied with certain ideas. With the temporal problems, you can be aggressive sometimes. So, yes, now coming to the blood supply, Blood supply is supplied by the internal carotid system and vertebral system, and of which the middle cerebral artery supplies the lateral half of the brain with the three branches: orbitofrontal, anterior, polar. And then if you look from the above and you see the anterior cerebral artery supplies the middle portion of the brain anteriorly, and posterior cerebral artery supplies posteriorly, that is occipital cortex. And if you just look at the posterior, the cycle of Phyllis is formed by anterior, middle and posterior cerebral arteries, formed by communicating arteries, and supplies the base of the brain. Now we'll see how to perform a clinical neurological examination at the bedside. We will go in an order like higher function, cranial nerves, motor, sensory, cerebellar. The higher function test, usually we use mini-mental scoring system. That means we have a questionnaire with orientation, memory, recall, attention and calculation, as well as language. We'll see one by one. If the patient is oriented to the time, like what's the day, what's the week, month, etc., and what's the orientation to place, where is the patient, in the hospital, in the house, and etc. And now we will check the memory. The examiner names 3 unrelated objects and check if the patient is able to respond and remember all the 3, and ask them to count backwards or spell backwards with the numbers. So that's how you check the memory. Now you recall. After some time, what the objects you showed earlier, you ask them to rephrase again, and then ask that show a wristwatch or pencil and them to name, and then make the sentence repeat the phrase, no ifs or buts, and put on a mark. And calculation. Ask them given instruction, take a piece of paper in your right hand and fold it in half and put it on the floor. So see whether the patient is able to focus your instruction. Ask them to draw a hexagon as you show, and test the language. Just make an instruction and close your eyes like that, let them read and do it, and ask them to make up a sentence, let him write with a noun and verb on his own. So all that you put a mark and just sum up, and if it's less than 23, the patient has got a cognitive defect. So that's higher function. Now you want to proceed to examine the cranial nerves. So you have 12 cranial nerves, and number 1 is olfactory. So you want to check the olfaction, the sense of smell with each nostril, with a popular odor which is available nearby, and ask them to close the eyes and see if they can smell it. And then you check the optic nerve with visual acuity, field of vision, and the color vision. And field of vision you confront and do it, and with the Snellen chart see the acuity, and then with the ECRS check the color vision. And also 3, 4, 6 cranial nerves can be tested uniformly with the normal eye movements, and if you see if there is a suggestion of third nerve with down and out movement, ptosis and pupillary dilatation on left eye, and say that's third nerve. Now ask the patient to look down and out, and if the patient has got diplopia, that is fourth nerve palsy. If the patient cannot abduct on one side, this, and then proceed to accommodation. Ask the patient to focus far and near using the pencil and see the pupillary dilatation. And the second case, ask the patient to switch between 2 objects and nystagmus, any involuntary movement. The first component is pointing to the side of the nystagmus. Check the trigeminal nerve. The whole face is supplied by the sensory aspect of trigeminal. So piece of cotton and check the face, and then look for the masseter tone after the patient clinches. And look for the 7th nerve palsy, and see the motor component of the wrinkling and closing the eyes. And vestibulocochlear you check with the tuning fork, Rennie's, Weber's, etc. Glossopharyngeal and vagus is tested together with the palatal upliftment. Now you check the spinal accessory. There's 11th cranial nerve, which is the sternocleidomastoids on both sides, and trapezius are supplied by 11th nerve, and you check like this by twisting the hand against opposition and then shrugging your shoulder. Now hypoglossal nerve, ask the patient to put out the tongue. That tongue movement is controlled by 12th nerve, and look for tongue deviation. Yes. And now moving on to the motor system, You, as the patient, lie down and check the arm and leg by checking the power and grade it to 1, 2, 3, 4, 5, and ask the patient to move passively the tone, hypotonia, hypertonia, clonus, etc. And do the reflexes, superficial and deep reflexes including brachial, tricep, knee and ankle jerk, and also test for plantar for its response, whether it's flexor or extensor or Babinski. Sensory system. So you have 3 senses: touch, pain and temperature, and do the touch using the cotton wool from head to toe, arm and legs. So as the patient will close eye and see, they can appreciate on both sides, and you can do also the pain, but usually you don't do it. And the vibration sense is checked by the tuning fork of 128 on the bony prominences. Also check the position sense of the, as the patient will close and see where they can appreciate the position of the hand or toe. Cerebral functions, see whether the patient has got a hypotonia, scanning, a staccaning piece, nystagmus, dysmetria, and dysdiadochokinesia, and atoxic gait and poor in coordination. Patient not able to put the dots in, cannot the knee sliding. And the fundus examination is again a part of the neurological examination. Remember that. And also ask the patient to walk and see the walking style, the gait. The patient got hemiplegic gait or spastic gait, or the patient got short suppling gait or atoxic gait. Right, so you end up with certain signs, UMNS signs, that's upper motor neuroscience, spasticity, hyperreflexia, clonus, plantar extensor, spastic gait. What about lower motor neuron signs? It's a second order neuron defect, the flacidity, hyperreflexia or absent reflex, plantar, flexor are absent. And what about the extrapyramidal signs? So slow movements, rigidity like cogwheel, dystonia, movements, abnormal movements, choreoathetosis, hemibalismus, and rebound. To summarize, the knowledge of anatomy, including functional anatomy, helps to localize the lesion. Understanding the blood supply helps to diagnose the vascular etiology, and a thorough, proper clinical examination will give you to make the clinical diagnosis effectively. Thank you very much.